In this video, we're going to take a look at the different ways that bone grows. A couple of different types of bone development. Intramembranous ossification means that it happens within a membrane. In this case, we're talking about fetal bone development. And the best example is the cranial bone development within the fetus. Later, our long bones begin to develop, and they begin to grow through cartilage, not through a fetal membrane. At that point, the membrane has differentiated into an adult tissue, and so we see these long bones growing longer. Endochondral, by the way, means within the cartilage, within the membrane, within the cartilage. Ossification means to transition into bony tissue. Ossified means turned to bone or turned to stone. Intramembranous ossification takes place within this tissue called mesenchyme. And I want to show you a really cool picture of fetal intramembranous ossification here. Great picture. Sadly, this is a picture of a fetus who didn't quite make it, but we can see here in blue the mesenchyme. This is embryological tissue, very stiff jelly that provides a primitive framework for the building of the body. In this tissue, we see that the mandible and the zygomatic bone and the maxilla and the nasals, the frontals. Look at this little temporal bone, this little zygomatic arch. Everything here in purple is just the beginning of osseous tissue. So here at about 12 weeks post-conception, we have just the very first beginnings of intramembranous ossification. Now, when long bones grow longer, they're going to use a different form called endochondral ossification within the cartilage. And we see that here. The tiny fetal bones begin as cartilage, and then we have some calcium begin to stiffen that so that the osteoblasts have a framework. They begin to lay down true bone, both in its compact and spongy forms, and then eventually we're going to see these secondary ossification centers so that the head or epiphysis can really grow and take on the adult-like shape that we need it to. You can maybe recognize this as a tibia, by the way. Here's the tibial plateau and the medial and lateral condyles. We need that tibia to be just the right shape, and so we can go from a primitive ice cream cone sort of structure to a very specific and completely ossified structure gradually over time. And it is really the secret here is the fact that this cartilage in the epiphyseal plate remains for some time, right? Maybe until you're 18 or 19, depending on the individual. When you're finally done growing taller, then that would completely ossify. So we no longer have an epiphyseal plate, it's now an epiphyseal line. And you can tell where it is because it's passing through a tissue that should be spongy bone, but like a bridge, we see compact bone going all the way through the epiphysis. That's the epiphyseal line. There's another type of growth that occurs bone on top of bone. So the bone isn't growing out of a fetal tissue or out of cartilage. And so, of course, there's another way, and so another term. Apositional or appositional growth is how bone grows wider. There are some excellent videos and Connect activities showing how this occurs, where the little blood vessel on the surface ends up being surrounded by new bony matrix until it's in a tube, and then these concentric rings, concentric lamella, moving in and in and in until they completely surround. and that's what ultimately forms the osteon. So it isn't quite like I had told you about the little village. They move into the outside first, and then the very last layer to move in is right next to the nutrient source. This is appositional growth. Size and shape of the bone can, of course, be determined by our genes, but it's severely influenced by nutrition and hormones like growth hormone and testosterone, thyroid hormone, estrogen in ladies and testosterone primarily in men helps to account for the skeletal structural differences between men and women. Women tend to have wider hips. Men tend to have more profound facial features, larger and thicker brow ridge, wider shoulders, etc. So we know through research, and clinicians have been for many years recommending weight-bearing exercise as a way of helping to build bone mineral density. And now we as students, we can learn and see why that is. Wolff's Law. Bone under stress gets bigger and stronger. I don't mean anxiety or fear here, but actual physical stress helps to stimulate this trabecular pattern to change. We can actually see this most clearly back here on slide number 14. These lines of stress in an upright walking bipedal creature create the trabeculae that distribute that force. So this is actually beautiful from an engineering perspective. I mean, these are arches. These are flying buttresses, people. It's like a great cathedral allowing this very strange shape to bear a tremendous amount of weight. When we see patients who are bedridden or who have metabolic disorders, suddenly we see a lot of bone mineral density loss. And so the flip side is, if you want your bones to grow stronger, you have to use them by walking, by lifting, yoga, all kinds of things to stimulate that physical stress, which will stimulate the osteoblasts to lay down more bone mineral density. And we see here increases bone mass and aligns the trabeculae with stress. When we break a bone has to go through a series of phases to repair that fracture. The first one is called the hematoma formation, and this really tells us how vascular bone tissue is. When we break a bone, not only does the matrix break, but we break open many, many small blood vessels, and sometimes some large ones, depending on the type of the fracture. Once the clot has formed, and we're no longer bleeding into that internal space, over the coming days and weeks, we'll have what's called the callus formation. So blood vessels actually begin to grow into the clot, which is a bit strange, but it helps to bring in white blood cells and new stem cells, the chondroblasts, to begin to remodel that blood and clot tissue into a framework for bone. Eventually, we're going to see that callus calcify or ossify. And then the little zambonis, the osteoclasts, come in and begin sort of polishing off the rough edges and turning over the bone so that we can really restore that density. Here's a nice visual. Ouch, you have broken your bone, and you're going to see a lot of swelling, a lot of inflammation here. Notice this isn't the skin, but the periosteum. This is very sensitive to pain, by the way. The bone itself doesn't have nearly as many nerve fibers as the periosteum does, and so oftentimes when people fracture a bone, they experience really acute pain. Bone cancers as well are characteristically painful, and it's because the periosteum begins to get irritated from the tumor. So after the fracture has stopped bleeding and the clot formation, those new chondroblasts are coming in to lay down cartilage and collagen. And so it's really sort of setting up the stage for a repeat of the endochondral ossification, right? We start with cartilage, it begins to be ossified, and then over time, the callus is sort of polished down, and we see a situation where the bone is hardly different from what it was before. Now, again, this really is highly variable, and it depends on the nature of the fracture and if it was displaced, if we had bones that were out of alignment and if they were put back into alignment, and if there was a cast involved. Sometimes orthopedic surgery and screws and plates need to be utilized to help to pull this bone into alignment. The next section, calcium homeostasis. In our last little section here, we see this idea of bone being a mineral bank. So imagine this. You have a great diet, lots of dark green leafy vegetables, and dairy foods and beans, things that are high in calcium. You absorb that calcium as long as you have sufficient vitamin D, by the way. And then the calcium within the blood is stored in the bone. How do we store calcium in the bone? By turning it into bony matrix, and that's the job of the osteoblasts. Later on, when you may be deficient, you don't have enough calcium coming in through the diet, no problem, we can just tap into our reserves. And we see here that it's the osteoclasts that dissolve the bone and allow the release of calcium into the blood. Parathyroid hormone and calcitonin are these two hormones which are going to be working in opposition of one another. So here's how it works. If the calcium levels are high, we want to tone down our calcium, calcitonin. Look at this, it inhibits the osteoclasts. It has some effect on the osteoblasts too, putting new calcium into the bone, right? If our calcium levels are low, the parathyroid glands release parathyroid hormone. Parathyroid hormone stimulates the osteoclasts to begin to chew away at the bone, allowing more calcium to go into the bloodstream. We also see that parathyroid hormone has an effect on our vitamin D production. PTH stimulates active vitamin D formation. Our kidney can make a little vitamin D2, and then the liver converts it into vitamin D3. We get most of this from sunshine, by the way. When ultraviolet light strikes cholesterol in our skin, it converts that cholesterol into vitamin D. Vitamin D2. Effects of aging on the skeletal system. When you get old, it all goes downhill. Right? As we age, especially ladies, due to menopause, we see significant decrease in bone mass. Our bone mass actually peaks around the age of 30 and then slowly declines over time. Let me just show you a quick picture of what I mean. I meant to get this one up here. Bone mineral density gender. So look at this. Bone mineral density peaks around 30, and then we see a slow decline over time, particularly in women after menopause. So look at this. Why do men tend to have higher peak bone mass? Well, testosterone, namely, could have something to do with gender differences in terms of physical activity, but it's primarily one of hormones. So guys tend to have bigger, bulkier frames than do our female counterparts. And then look here. Gentlemen, we slowly decline with age as our testosterone slowly declines with age. And ladies, because of menopause, although this slope could be shifted one way or the other. Our average peak menopausal decline here somewhere in the late 50s shows that when the hormones crash, there is a sequential decrease in bone mineral density. Hormone replacement therapy could have an effect on this. Medications like Fosamax could have an effect on this. But I think the take-home message here is, ladies, you got to do everything you can when you're young to try to get this line up as high as you can so that it doesn't decline or quite as quickly. A couple of quick things. Cigarette smoking decreases bone mineral density. Frequent cola consumption decreases bone mineral density. And sedentary lifestyle and poor nutrition can also exacerbate that. So take vitamin D, take calcium, get some exercise, quit smoking. For goodness sake, stop drinking soda, and that'll really help to get your bone mineral density back up where it needs to be before you head down that long, slow decline. Wow, what a terrible way of saying it. Looking quickly here at the bone fractures. Complete fractures go all the way through from one cortex to the other. Incomplete fractures look a bit more like a green stick fracture, right? It doesn't go all the way through, but we can see obvious here hematoma formation. Comminuted, sort of a shattered, transverse, impacted, where one has been driven up into the other. This is not uncommon for a hip fracture, right? For that surgical neck to become so osteopenic or osteoporotic that it just collapses right up into the head. Spiral fractures, and sometimes these can be very long, and oblique fractures, angling from one side to the other. I hope you found this video helpful and mildly entertaining.